When I first learned about direct primary care, I thought it was too good to be true. As I continued to dig deeper, I realized that the DPC model inherently creates more opportunities for organizational health literacy to be prioritized, which is why I am so glad to be joined by a DPC physician today for this episode of Health Literacy in Real Life. Welcome back to Health Literacy IRL, a show where we move beyond personal health literacy and instead look at how systems, organizations, and care models can make it easier for people to understand and use health information in their daily lives. I'm Megan Freeland. I'm a public health pharmacist whose work is a blend of health literacy strategy, patient advocacy, and patient education. Today, I am joined by Dr. Byron Jasper, founder and CEO of Byja Clinic. Hailing from Houma, Louisiana, Dr. Jasper is an alumnus of Xavier University of Louisiana. He earned his medical degree from Tulane School of Medicine, as well as a master's degree from Tulane School of Public Health and Tropical Medicine. He went on to complete his family medicine residency at Baton Rouge General, then became board certified in family medicine upon graduation. Dr. Jasper furthered his expertise with fellowships in community health leadership development at Georgetown University School of Medicine and HIV and hepatitis C care at Providence Hospital in Washington, D.C. In addition to his clinical work, Dr. Jasper is the author of Byja Blueprint, an introductory guide to direct primary care for doctors, patients, and businesses. It's a book that's useful for both healthcare professionals and patients who are interested in learning more about DPC. And in this episode, we are going to learn much more about the DPC model and how it creates space for organizational health literacy to be prioritized within the patient-provider relationship. Byron, welcome to Health Literacy in Real Life.
Hey, thank you for having me. That intro sounds too good to be true. I don't know who that guy is, but sounds pretty cool.
He's sitting right in front of us, and we are so grateful to have you here to educate us more on what direct primary care is and how it can benefit the entire healthcare system. So, why don't you start out by telling us a little bit about how you describe the type of medicine you practice and what the DPC model is all about?
Yeah, so I think direct primary care, for the most part, is about inclusivity. Most of the misconceptions that we hear is that it is only for the wealthy or only for the people who have a lot of means, and that can be very misleading for a lot of people. So it almost turns them off from the model before they even get started. So
Mhm.
for my model of DPC, and I say my model is because what we say in the book and also just in general, if you've seen one DPC practice, you've seen one DPC practice, which is our way of saying we're all very unique. So my version of DPC may look different than the doctor who's up the road from me, who's in a different from someone who's in a different state. So for our version, we believe in giving access to all people, regardless of their, gender, their race, their sexual orientation, their socioeconomic status. We just want to take care of people. And that's why I went to medical school, to take care of patients that are people first. That's how our clinic started, and that's the way we practice. And we've been going strong ever since we started.
What inspired you to transition into that type of care model? I know you must have had some experiences before you launched and opened Byja Clinic. Can you tell us a little bit about what your experience as a family medicine practitioner was in the more traditional models and what led you to transition to DPC?
Yeah, I think the simple fact that most people know the system in a very shock value kind of way is the best way I can explain it. That it's a system that we have. It's not a system that we love. It's one of those like, you can go to the restaurant that's up the street and it doesn't mean you really like the restaurant. It's just close. So it's what you got. It's not what you really love. The one you love is literally in another state or another town, but you don't want to travel all the way over there. So for us, the traditional model is kind of what you have. Most people know that it's not good. They don't really like it, but they deal with it because it's what they have or it's what's accessible to them. And that's my experience when I was a practitioner in the traditional insurance based model. I didn't know any different. I didn't know there was a different system. I didn't know there was a different model. So I just went into it and did what everybody else does, which is deal with the insurance based healthcare system and all of its bad and good and, for lack of a better term, ugly. And what ends up happening with most doctors who are in that system, you start to get really turned off by the system. You love your patients, you love your coworkers, you love taking care of people, you love giving awesome care. But then you start to realize that no matter how much work you put into it, there's always more stuff that keeps coming your way that isn't really palatable. You're dealing with negative things like prior authorizations and pharmacy benefits managers and things not being covered and patients having to wait long times to get in to see you and you having endless amounts of charts. All of those things are very normal in the traditional model, and people don't like it. They just deal with it. And after doing that for, I say, 4 or 5 years after finishing my last fellowship, I just felt like it wasn't right. It wasn't the way I thought medicine should be practiced and delivered to patients, especially those that are in the underserved community who often need a lot more time, a lot more care, and a lot more resources. So for me, something in my mind always said there has to be a better way. And when I learned about DPC, which is a very weird story, and I'll, maybe we'll get into it. When I learned about it, I ended up checking into it by going to a conference and found my proverbial village. 2019 is when I went to the conference. I opened my practice in 2020, and we've been going strong ever since.
Okay, so if you learned about DPC in 2019 and you
Mhm.
opened in 2020, that means that the time period from which you learned about it to which you acted on it was quick, and you
Mhm.
you immediately felt at home and like this was the place for you. So tell us the weird story. I would
Mhm.
like to know, how did you find out about it?
Yeah, so the funny thing is I didn't learn about it in 2019. That's when I would say I discovered it. I learned about it in a very distant kind of way. After reading an article in the Family Physicians Journal, we have a governing body called American Academy of Family Physicians. We say AAFP. So AAFP puts out a magazine for the most part, or a journal, once a month. And for some reason in that journal, which I skimmed through, I found that article. No idea how I found it, and I'm pretty honest and transparent with you. I don't read them journals. They are a waste of paper. Let's just be honest, because they're killing trees. That's just me. So based off of that, me finding an article in a publication that I don't really read is really weird. But I read it, and it literally just stuck with me. And that was in my residency program. Sometime in my residency, in that 3 year window, I read that article. Then I left and did fellowship for 1 year. I did another fellowship for a second year. Then I practiced for 5 years, and I still remembered that article. I
Mhm.
just remembered that concept for almost 6 or 7 years and never thought anything about it other than that just sounded like what I wanted to do. It sounded like the way medicine was supposed to be practiced. And once I literally said, let me go find that article, I dug through my email because after I read it, I went online and I must have saved it, and I found it buried in my email somewhere, and I read it again. And after I read it again, I just literally went down a rabbit hole. It was literally on the internet. I was like, I got to figure this out. So looked at one conference about DPC, and then looked at a video about DPC, and then read about this clinic about and it just literally just kept coming. To eventually, I said, I'm just going to go to this conference. Like, don't know anybody, didn't know anything about it other than what I read online, and
Mhm.
that was my motivation to go. But the biggest thing I think was a motivation for me, I saw one video with a black female DPC physician on a stage talking about her practice, and it automatically hit me like, if another person of color is doing it, I can do it too, right?
Mhm.
That whole idea, you can't be what you can't see. It really was one of those things. Like, all I had saw was a lot of non-black physicians on a lot of the articles and the journals and the videos. So when I finally saw that one person, it was like, I got to give this a shot. And that's when I went to the conference. And funny enough, the person on the stage, I met her at that conference, and we've been very good friends ever since. And she was so welcoming, so warm. She was like, yeah, you need to do this. I've been doing it for 10 years. I mean, what's taking so long, right? Like, just super motivating that in 2019, I literally was like, you know what? We're doing this. And that's why I said, for me, I'm very much resilient. It's going to take a lot to get me to not do something. And
Mhm.
even then, it's going to be damn near impossible to get me to say no unless I want to say no. So for me, once I said, even though I know it's going to be a challenge, even though I know it's going to be difficult, it felt right to me, and it gave me the sense that this is the way people should receive care and how we should deliver care. And from there, again, I've been DPC ever since. And I'll finish up by saying this because I know that's a very long answer. With that conference, when we actually met and had the conversation and all that, the person I trained in one of my fellowships,
Mhm.
because again, as a fellow, you kind of train residents. I saw one of my residents at the same conference, and she said, oh, I'm starting my DPC practice as well. So I'm like, so my resident who's younger than me, who I taught is starting one, what am I worried about?
Mhm.
Like, that gave me even more motivation. Like, it really is one of those things where you can be fearful, but you shouldn't let that stop you. And me literally starting my practice in 2020 during a pandemic in a model that most people don't know, where we don't really use insurance, and you got to trust this black male physician to take care of you in a new model and do it paying out of pocket. Like, it was really insane. But now that I look back, I'm glad I did it because I was the first black DPC physician in the state of Louisiana in 2020. And since then, we've had so many that have come after me. And I just really love the idea that we're doing something that's right for people, and people have supported us.
I'm glad that you shared that story. It's such a beautiful example of how, those ideas get planted in our minds. And even if we're not quite ready to pour water on that seed
Mhm.
yet, it sits there and you're able to come back to it when you need to and when you're supposed to.
Mhm.
I want to come back to your experience of opening this clinic in 2020 and what that experience was like for you as a physician, but also how you were able to support your patients in that critical time. Before we get too far into it, though, give us a one on one lesson
Mhm.
of what direct primary care actually is. For context, I did have a pharmacist who works in a DPC clinic on the show, and she
Mhm.
gave us a very brief overview, but I would love to hear from your perspective as an owner of a direct primary care clinic. How do you explain it to your patients when it's very out of the ordinary for what people will expect?
You're paying to be a member of a medical practice out of your own pocket. That's the simple, short, sweet answer. And a lot of people can understand that. Those that can't understand it, I say that is like a gym membership for medicine or like Netflix for medicine. You go to the gym, you pay, you get to work out as much as you would like. Netflix or any streaming platform, you pay, you get access to their services as much as you would like. For us, you pay the doctor or the clinic, and we give you as much medical care as you need. We then go into kind of what are the perks of being a member. Like if
Mhm,
you're a member in a big box store like a Sam's or a Costco, you get a lot of benefits by being a member versus a non-member. So when we tell people these are the benefits of being a member, most people who really understand and know what they're looking for are, where do I sign? The
mhm,
people who get confused are those who often have insurance and they're wondering, well, how can I use my insurance with this? Or why would I do that if I have insurance? Because insurance, yada, yada, yada. And most of the time, the people who say that, they don't really like insurance. They just feel like because I have it, I'm supposed to use it. And when we talk about the idea in any other industry, how much do you use your insurance? You would hear a whisper if someone says, I've used it once or twice in the last 2 years. Your
mhm,
homeowner's insurance, unless you had a really catastrophic event, you usually don't use it. You pay for it, you just got it. Car insurance, unless you drive horribly, you're getting into accidents or getting pulled over, you usually don't think about your insurance. You just pay for it and you keep it moving. But in healthcare, we use our insurance so much. It's why everything's so expensive. It's why premiums are going through the roof and the subsidies and all that are running out. It's because it's gotten out of hand that you're using it 7 or 8 times in one transaction. Where you see the doctor, you basically filed 3 claims. If you filed 3 car insurance claims in a day, people would look at you like, what were you doing? Were you robbing a bank? Like, what were we doing that allowed us to use our car insurance that much? It
mhm,
doesn't make sense to do that in healthcare, but we're trained to think we have to. So when we get people to realize insurance should be something you have and you use it for big stuff, everything else should be more transactional directly through you and the vendor. Most people understand that in other industries, but in healthcare, we're having to unplug people from that matrix to get them to get that concept. But once they get it, it usually is pretty easy. We still have some that get a little confused because, they may just really not have the health literacy. But when those people get it and we really get them on that granular level to know, first question is, well, how much does it cost without my insurance? And
mhm,
once we tell them that, and then we tell them, well, if you file with your insurance, you can figure out if we are lower or if we're higher. Then you make that decision. And once they start doing that, they're a better consumer. By being a better consumer, they have less claims that are arbitrary. And then from there, they have savings down the road because they're now filing less claims and they don't need these crazy insurance premiums where they're not really using it. And
mhm.
that's the way I think it should be.
So, one common, let's say, complaint or criticism that I
Mhm.
hear of people who may not be as familiar with the DPC model is that it's exclusionary
Mhm.
and that it creates an additional financial burden for patients because without being able to use their insurance, many people are not able to afford the monthly membership fee for a DPC relationship. One of the things that you mentioned is that DPC is very inclusive, or at least that's your priority in your clinic. So how do you engage in those conversations?
Yeah, I think it comes down to what is the goal of the person who's potentially trying to access DPC and what is the goal of the practice who is delivering DPC. If
Mm-hmm.
those two people want to make it work, they can make it work. The issue is people want the best care, the best service, but they want the cheapest price, right? They want the Rolls Royce of cars, but they want to pay for the Geo Prisms that they're not even made anymore, and they want you, Dr. Jasper, who went to school for 10, 15 years, to spend 4 hours with you, but they won't pay $10. Don't make sense. That's not how this works. It has to be an exchange of goods that is equitable and fair on both sides. So I'm not going to tell you you need to go pay $2,000 to see Dr. Jasper. I don't think that's right. But you also shouldn't expect Dr. Jasper to take pennies and then he's now in a financial strain trying to keep his clinic open and feed his family, but you are over here living and enjoying your life to the fullest because you expect him to spend all this time with you. That's how we got into the system and the mess we're in now, where the doctors are having to stay until 8 or 9 o'clock at night doing 50 charts a day, not getting paid nearly as much as they probably should because a third party is taking the lion's share. Patients are getting very bad care, and the only people in the system that seem to be happy are the people who don't do any of the medical care or receive it. So
Mm-hmm.
the misconception of, well, you have to give care at a dirt cheap price, I think that's wrong. You have to give care at an excessive price, I think that's wrong too. So we just have to find a meeting in the middle is the first thing. For us and a lot of clinics around the country, what I've seen happen is they either will have a reasonable price for most patients that are accessible. They may have a higher tier for patients who have a little bit more means. And then they give what we call scholarship care, where you make exceptions for certain patients who may not be able to do either of those two. They don't advertise that they're going to give free care out to everybody, because if they did, they wouldn't have a business, they would have a charity. And at
Mm-hmm.
that point, charity, you're basing your care on other people giving you money, not the people you're delivering services to, like nonprofits. So you can definitely do it in multiple ways. In our clinic, we try to make sure our prices are reasonable. We're in a capital city, so our price point may be a little bit higher than people in a rural town or a rural part of a state. But the other part for me is that, again, what is the intent of the clinic? Our intent has always been to give care to people where it is equitable and fair on both sides. So I know that if our price may be higher and people still want to access care from us, we started a nonprofit arm to give charity, where people like Megan could come and say, I want to make a donation to your nonprofit because I know you give good care. I want you to be paid the way you need to be paid to take care of your family and your needs. But I also don't want the patient to be in a financial strain. So I'm going to donate to your nonprofit. I get my tax deduction. And now patients can get care for free and you still get paid and everybody is happy. So
Mm-hmm.
you can do that. You can find a solution. What people want is DPC to fix everything in the broken healthcare system that's been broken for 40, 50, 60 years. And they want the primary care doctors to somehow fix surgery, be a hospital doctor, be a pharmacist, figure out how to do insurance, figure out how to be an emergency room doc, and then come back and say, well, it's not good to do everything. So why would we do that and not take insurance? Well, let's look at insurance. Does it really cover everything? No. Is it efficient when you go to the clinic to get in and see people in a way where you don't have to wait? No. Are your medicines covered in full? No. Do you get in pretty quick when you need an appointment? No, it's usually 3, 4 weeks or 3, 4 months. So insurance is horrible, and you're saying we need to somehow do exactly what insurance does. Why would we want to follow that? Why would we want the doctors to fix everything with one fee and figure it's going to work efficiently? That's what insurance gave you the smoke and mirrors to believe. They made you think that by having this insurance card in your wallet, you're going to get everything covered. Then when you go to use it, you realize you don't get anything covered, but yet you've been paying into it. So people have been tricked and brainwashed into thinking insurance is great. And somehow, since DPC doesn't do what insurance does, it's not really good. It's backwards. If you realize that direct primary care is for primary care, and that alone, you will then get into a space of, okay, anything beyond this, maybe when I break out my insurance card, then I think we have started somewhere.
Mm-hmm.
If not, anything beyond this may be an additional cost. Then you'll understand that. And the more we get people to start taking healthcare and comparing it to these other industries that we talked about, I think people will understand better. And we have our own podcast, and I know you know that. When we did one of our most recent episodes, my co-host, he calls himself Patient Zero, he said, very eloquently, when you go to get service at a mechanic, I'm pretty sure they don't change your windshield if you got a windshield problem. I'm pretty sure they don't give you gas in your gas tank if you need gas. You go to those individual places and pay separately. If healthcare started to do that, where you knew you were going to Dr. Jasper and you're going to pay Dr. Jasper, you go to the surgeon, you're going to pay the surgeon, you will start to see a change in how things are delivered and the cost, because transparency is now happening. But right now, we have this card that makes us think everything is pretty confusing. So you don't know how much anything costs. You just know so and so takes your insurance, and it just turns into a big mess. So if
Right.
we can get people out of that mess, it works. There's so much to cover that we would have to possibly do this show 2 or 3 times in a row to cover
Mhm.
every aspect that people like to bring up because they want DPC to fix things, and it's not intended to do that. It's not intended to cover your hospital stay. It's not direct hospital care. It's called direct primary care. So when
Mhm.
you come in and say it doesn't cover hospitals, it's not supposed to. We're not supposed to go to the hospital because, again, you go to the hospital to see the hospital doctor. If Dr. Jasper is going to the hospital and doing your surgery and in the emergency room, I don't think that's a good thing. Number one, Dr. Jasper's not trained to do that. Number two, I'm pretty sure I'll be tired trying to do all those things. And number three, how do you expect that it's going to be efficient if I have to do 14 jobs
Mhm.
and still care for 200, 300, 500, 5,000 people? Like, it just makes no sense. I'll wrap up by saying it's because people fear what they don't know.
Mhm.
Rather than educating themselves and learning how this works and really peeling back the layer by layer to get it, they just dismiss it and say, well, we're going to stick with the evil that we know. And it's not helping anyway. So you're just making a situation worse by turning people off from something that could be helpful and sticking with something that's already tragic. Like, it makes no sense to me.
Yeah, I think what you're highlighting here is like the importance of leading with curiosity and interest and a desire to learn and understand. And that's not to say that everyone will necessarily agree with every aspect or DPC or think it's for them or think it's for most people. Maybe they won't. But and I think one of the goals in having you on the show is listen and learn and explore and understand what the intention is and where DPC can be useful, because I think it can be useful for a lot of people in a lot of different situations. Can you share with us some of the features, so to speak, of maybe your clinic in particular? Because as you
Mhm.
said, you've seen one DPC, you've seen one DPC. So let's talk about Byja Clinic specifically. What are some of the benefits that members
Mhm.
are able to experience? And if you can highlight any of those that really, in your opinion, help to further health literacy and enhance that health literate relationship with your patients, that would be wonderful.
Yeah, I think the biggest one is time. What we lack in the traditional model is time. It's a lot of wasted time, right?
Mhm.
So when you get to the office, you're in the waiting room for 30 minutes. And then from the 30 to 45 minutes of waiting, you then get to the back and you may have to wait another 30 to 45 minutes. So you've been there anywhere from an hour to 2 hours waiting to see the doctor. Then they come in and they're in there for 10 minutes, 15 minutes if you're lucky. So in a 2 hour and 15-minute appointment, you've only spent 10 to 15 minutes on your health. That is a colossal waste of time. In no other industry, if you had to do that exact exercise, would you continue going to that place? In the
Mhm.
book, I wrote about the concept of if you went to a restaurant and they literally made you sit in the waiting area of the restaurant for 45 minutes. Then you got to your table and had to wait another 30 minutes for the server and the food to come out. And then they rushed you through your meal in a 10-minute window. How many times would you go back to that restaurant? Most people would say never. So at this point, we're basically glorifying this system where time is really not as important as we often think it is. In our system, health literacy comes because we have more time. In my old practice, I would probably never have time to sit down with you in the middle of a clinic day and record an actual podcast and talk about a model and do all this and still have time to care for patients. Like, it just wouldn't happen. I'd have to block out my clinic for a whole day to potentially prepare and sit down and have this conversation with you. So by us having more time with patients, that improves outcomes. Our minimum visit is an hour at my clinic. Some people have 30-minute slots, some people have even longer, but we have an hour because that hour allows us to spend time with patients.
Can you think of an example of a time that you've been able to have a breakthrough with a patient because you had the time and the capacity to be able to really dive in detail with them?
I have a pretty significant number of black males who come to see me because they believe that they are more comfortable having a black male physician. And my patient from yesterday, who literally came in after not seeing a doctor for several years, was able to say that he is now able to feel better
Mm.
because we treated his anxiety and his depression that was never diagnosed. Mental health is often hard to pin down and diagnose because a lot of times it talks about feelings. So in men, it's hard to diagnose because a lot of times men don't know how to express feelings. They know usually a couple of feelings. I'm upset, I'm mad, I'm angry, and it's rare like I'm sad
Mhm.
or I'm anxious. Like those aren't words most men say. So for him, we were literally diagnosing him with high blood pressure, and his blood pressure was just really hard to treat. And I said, "How are you sleeping?" And he's like, I really don't sleep. I'm usually staring at the ceiling, just not sleeping. So after an hour appointment of us literally talking about what's going on in his life, how is he feeling, we said, let's try this screener. And then with the screeners, I brought it up because the lowest on an anxiety screener is a 0. The highest is a 21. Any idea what his score was?
Off the charts.
I'm going to go 21.
Mm.
So he had the highest score possible on an anxiety screener. And he's like, no one ever told me I had anxiety. And, he's in his 40s and never ever had that conversation. So I bring that up to say this was about 2 months ago when we had the initial conversation and the follow ups and things like that. So he came to see us yesterday. And I say, well, how are you doing? He said, I'm doing much better. I'm sleeping. Things don't bother me as much. I really feel like it is helpful that I'm on treatment and going to therapy and all that. And I never would have did that had I not been in care with you. And the part that was a breakthrough for me is he said, I actually talked to my brother, and my brother said, I've been having the exact same thing happen. I never knew what it was. And had he not got treated, his brother, who's now in treatment with a different doctor, which is great, would have never known because apparently his doctor never even talked to him about anxiety or depression, even though he's in treatment in the traditional model. Because, of course, there's a lot of things that could be an issue. But one thing that we know isn't an issue is that our patient has time. He
Mhm.
has an hour each time to talk to us about what's going on in his life, what is or isn't being taken in terms of medications, what is his diet like, what are his financial problems, which God forbid we ever talk about finances in medicine. Like it's not something that even comes up. But in our practice, we talk about it all the time because if you're not financially healthy, then emotional health is going to be bad, physical health is going to be bad, mental health is going to be bad. So by us having time to address different things within the health field, I think literacy goes up for our patients because we're talking about these things in such a very basic way that they now learn and now go out and apply, in this example, the brother to his brother. And now his health literacy trickles over to his brother who gets better, and it works all out in the community, in my mind. And that's the way it should be.
Yeah, that's an incredible example. And you bring up a great point about financial health conversations and how they don't happen often enough in medicine. Often that trickles down to when you get to my colleagues, when you get to the
Mhm.
pharmacy, then the financial conversation is really important
Oh, yeah.
because, we're trying to help you get your medicine and your insurance doesn't cover it and you can't afford it. So
Hmm.
it'd be really helpful if you were able to have those conversations earlier in that pipeline.
Yeah.
I also love this example because of the kind of the racial, the gender, the cultural norms that it brings into medicine, which are
Hmm.
obviously a very relevant part of people's lives. Before we start to wrap up, can we go back to 2020 and can you share a little bit about how you were able to serve your patients really well through this model at what was a difficult time for pretty much everyone in the world?
Absolutely. So for us, I think one of the biggest things were that we were dealing with was the idea that people needed time. People were sick left and right. They couldn't get in to see their traditional doctor because the system was overran with all these sick people who came in with this disease that wasn't really well known and documented and studied at that point. So, for you to get in to see the doctor, we already had a bad system where the wait was horrible, and then you're in the room for a very short period of time. Now this is magnified because more people are trying to get scheduled because they have symptoms and they're trying to see this doctor who's already overloaded. It was just a really bad system. So in our clinic, that hour-long appointment was very crucial for a lot of patients to be able to come in and really unload on how they were feeling, not only from the viral illness, but blood pressure, right?
Mhm.
Because again, imagine two sides of it. Yeah, if you're having a viral illness, you want to have time to be able to get into and have discussions about that. But now imagine that same person is now flooding the waiting room. So the person who doesn't have any symptoms and needs to talk about their diabetes or their high blood pressure, they don't get to be seen. So that person now has to wait, and that's going to cause more problems for them. So we had patients who had no issues from a COVID standpoint, but they needed more time with the doctor to really talk about their diabetes. And if every other doctor is booked and they're now having shorter periods in the clinic, it's
Mhm.
not going to help them. So for us, we were able to take time with multiple patients with those hour-long appointments. So if you have an appointment with me, your appointment starts at 9, we start at 9. If your appointment starts at 10:30, we start at 10:30. So our patients never had to waste time in the waiting room, and they get an hour-long visit with me every time. And then on top of that, we don't charge by the visit. You pay a monthly fee and you get coverage for those 30 days or so. And at that 30-day mark, you can come in 30 days, once a day, every day, and it doesn't cost any difference. So patients never were apprehensive of picking up the phone and calling and now having to bargain with their health, as what I call it. My favorite bargain is, well, how sick am I? It ain't a real fever. My throat don't hurt that much, right? It is a little chest pain. Like you're bargaining on how sick you really are because you don't want to go into that bad system. You don't want to go wait in the waiting room for them to tell you, oh, you just have acid reflux. Oh, I took a day off from work just to be told that, and now I lost money. Like it's all these things that come into, do I really need to go to the doctor? So
Mhm.
we're putting it off 6, 7 months, and then come to find out when it isn't acid reflux, it is something with your heart. Those 6 months are crucial because now we've lost 6 months of time where the disease is getting worse. So by us having no waiting in the waiting room, hour-long appointments, unlimited visits where you're not having added cost, and the best part is access to the doctor when you need it. The clinic number rings to my cell phone, so when patients have a question, they just call me. It's not, well, I called the office, I had to leave 4 messages, he
Mhm.
called me back 7 days later. It's, I called the doctor, he answered, or if he didn't, he called me back. I text the doctor, if he didn't respond immediately, he texts me back. So by having that in a pandemic where your cost doesn't get any higher, your time is important, and you have access when you need it, not when you think you're going to need it. And 6 months later is when you finally really and truthfully need it. It just leveled the playing field for a lot of the patients, especially those that are in the underserved community. We keep emphasizing that we have better outcomes, and we know we do. And it doesn't take us to have big, egregious studies powered by so many pharmaceutical companies and third parties to prove it,
Mhm.
because that's what another thing we have from a criticism standpoint.
Mhm.
Well, there are no studies that show DPC. That's because we're not sitting here wasting all this time spending a lot of money on a study to tell me that my patient who had a 21 out of 21 anxiety score is actually doing much better, other than he told me himself. Like, I don't need a study for that. I can see it. They can see it. And
Mhm.
if we can do more of removing the BS and dealing with real hard facts of people need better care, and we need more transparency in medicine, and it needs to be cost effective. If we can literally agree on that simple amount of facts, everything else I think can get better. But in the beginning, you got all these people who are constantly fighting for a horrible system, and nobody's questioning, well, why are you fighting so hard for that system? No one ever says that. And a lot of times it's because either they are afraid of what we're going to do to fix the system, or they have an incentive to keep things broken.
Mhm.
So it really is it's a shame, but at the same time, I'm not surprised. But as we continue to push for it, we're seeing more breakthrough after breakthrough and having better outcomes, in my opinion, and I'm happy with it.
And even just seeing the growth of DPC over the past several years, it's been tremendous to watch. So I know that you're an incredible resource for your patients. And I think by being on this podcast, doing your radio show, and just evangelizing about the benefits of DPC, you're doing a great service to the whole system, because the math is just mathing differently for people. And it's just a
Yeah.
matter of getting them to see it differently, right?
Yeah. And you're going to always have people who just can't be convinced, right?
Hmm.
You might say, my favorite singer is this person, and you got somebody who flat out thinks that person just can't sing. Okay, why am I wasting time trying to convince you? You made your mind up. I'm not worried about those people. I'm not trying to convince the naysayers who don't really and truthfully want to even have an honest conversation.
Right.
I'd rather spend time on the people who are literally in the middle trying to just find what works better for them. And some people may find the insurance model works great. They don't have any problems. Their doctor is efficient. They don't ever have to worry about waiting. Their doctor calls them back. They don't care that they got to be in the waiting room for an extra amount of time because their doctor is great. Keep them. You're never going to hear me argue. Hey, you like Dr. Smith? Dr. Smith's awesome. Keep Dr. Smith. It's when you literally have problems, but then you call and you complain. And then I say, well, if you pay me out of pocket, we can eliminate that. Well, I don't want to do that because I mean, what I got insurance for? You tell me. You just told me all the problems you have. But now you're telling me you want to stick with those problems. Like, I don't get it. It's people like being people. Or as I like to say in my clinic, people be peopling. And
Hmm.
if they keep doing what they do, you can't change those people. But the ones who literally are willing to give us a shot and try the model, whether it's us or anybody across the country, 9 times out of 10, and I really mean that 90% of the time, they don't leave. The only times I've had people leave for the most part, it turns into financial issues or they feel like they want to try something else. And
Hmm.
again, I'm not upset about that. If you feel like our cost is not something that can work for you and we can't work it out through the nonprofit that we have, again, may not be a good fit. Everybody can't drive a Rolls Royce in this thing. That's all right. But we can find a way to get the people that need to be here. And I've had people literally rearrange their budgets to afford medical care, which I think makes sense. The people who get it, they come, and they love it. I'll tell you another quick story. I had a patient of mine who texted me last night. I was in the office. We close around 4:30, 5 o'clock, most people. I was in the office till 7 last night working on something for a patient. So I leave, and right before I walk out the door, a patient texts me and says, I'm sick. Can you bring me a COVID test? Because his house is on the way to my house. I said, absolutely. Do you want one or two? Patient fell asleep before I could get him the COVID test. And he literally texted me this morning saying, I'm sorry I fell asleep, but I still feel pretty ill. I said, well, you need to get in the car and come over because I don't have any patients right now. He's like, you mean right now? I said, yeah, right now. So in that conversation, he hops in his car, he drives over to the office, we do his visit. It cost him nothing. He needed something to treat him because he had strep throat. We treated him by being able to give him a prescription in the clinic because in my state I can dispense medicine, so I can dispense a small amount of antibiotics. He then gets the antibiotics, he can go right home and get back in the bed, and it doesn't cost him anything other than a small amount for the prescription. And
Hmm.
all of that took 2 text messages and 1 phone call. Like, I don't think anybody can argue that that's efficient and it's transparent. And he knew everything that was going to happen because he's been a patient of ours since 2020.
Hmm.
So, literally, that's the way it should be. It shouldn't be, well, if I go, how long am I be there? How many people are going to be in the waiting room? How much is it going to cost? Do I need an x ray? Like, it shouldn't be all that negotiating. It should be come in, let me take care of it. You go home and you rest. Doctor's got it. That
Hmm.
should be what it be. And by doing that, I think he feels better. I know I feel better because now that he's treated and getting better, he can carry on. He didn't break the bank, and I'm able to do what I was called to do, which is help people. So I think DPC works. It works for the right people, it works for those who are curious, and it works for those who are willing to give it a chance and not think it's a fix all for this bad system that's been bad for 20, 30, 40, 50 years.
Dr. Jasper, if we have any listeners who are in Louisiana, in your area, and interested in learning more about your particular clinic, how can they find you? But also tell us about your radio show, where people can
Mhm.
find that, because you, in addition to the care that you provide, do a great job of sharing information with the masses that can be helpful for their health and wellness journeys.
Yeah, absolutely. Number one, thank you for having me once again. When you reached out, I was pleasantly surprised because as much as we do the radio show, we do it from a place of like, we want to help people. So when we get listeners who say, oh, I listen to you all the time, it's almost like a, who, me? So when you reached out, I was pleasantly surprised. Patient Zero also says, what's up? So we have that radio show. It's called the Byja Radio Show. We're on pretty much all the streaming platforms, your Spotify's, your Apple's, YouTube, things like that. So definitely can check it out. It's usually out once a week. We try to do an episode a week to cover different topics, whether it's current events in healthcare or specific medical topics. I think the most recent episode we dropped yesterday was on kidney health and how the kidneys work and what they do. So, huge advocate for that. Our website is www.byja.org for Byja Clinic. Our nonprofit, if you're interested in looking at myself and other doctors who are a part of the nonprofit that give the equitable care where we're not causing patients financial harm, but they're accessing DPC, that is the Byja Charitable Alliance, and that's byjaca.org. And we're also on social media, Byja Clinic on LinkedIn, Byja Clinic on Instagram, and on Facebook. And of course, if you're really interested in just diving in and not sure where to start, the Byja Blueprint book, when we wrote it, it was literally the idea of I keep saying the same thing over and over. So maybe let's just write it down, and that may be a way for people to learn about DPC in a very high level. It's not
Mhm.
going to tell you what your DPC doctor is doing in Kansas. It's
Mhm.
not going to tell you what California DPC docs are doing. It's going to give you the outline and the framework of how DPC works. And as you get that layer and foundation, you then go further, and that'll help you open the door to that DPC in your community. But it's a really good introductory guide for a lot of people, physicians who don't know if the system is a good fit for them and why can it work for me. It's for them, for patients who don't know anything other than the system is bad and we need something else. It's good for them. And then for the business owners who, as I hear right now, my premiums are going up for all of my employees. I don't
Mhm.
know how we're going to afford it. It's great for them too, for them to know that there's a way for employers to access DPC for their employees and they get good care. The employers don't go out of business because they're sinking the ship for healthcare premiums, and we get to care for patients. So it's just a really good resource. I advocate for it all the time. And my favorite part, it's written in the most basic form because if you know I love analogies, they all up and through there.
I
Like
was
it's
just gonna say, if you have enjoyed Byron's analogies today, I
they in
think
there.
this primer will be a good look for you.
Yep, yep, absolutely. So again, thank you so much. I really appreciate the opportunity.
Everything you said in this episode is the exact reason why I invited you to be on the show. And I appreciate you for saying yes to my very random request. But to your point, I heard your show as I was just looking to learn more about DPC. I heard your show. I heard you and Patient Zero in describing your relationship and how you came together. And I just thought that, especially with you being a Black male physician, you would be a great voice to be able to come and educate folks about DPC. So I appreciate you for being here, taking time out of your day to educate the masses, and hopefully patients, fellow healthcare professionals who are listening to this have learned a lot as well.
Yeah, absolutely. Thank you again, and happy to be here. Always welcome as well for you all to come on over. At some point, we're going to have people on the Baja Radio Show. We haven't figured out the interview thing, but definitely got to get you coming on and doing the same thing where we get to introduce you to our audience and hopefully explain how health literacy is so important to them as well.
Mhm. Would love to. Would love to. Thanks.